Well, good morning, everyone. It's my pleasure to present to you today. We're going to be talking about Nocardia and Actinomyces. These are important infections that we occasionally see in hospitals and in the outpatient setting. In some ways, Nocardia and Actinomyces, which are related phylogenetically, are similar, and in other ways, they're quite distinct. And we're going to try to compare and contrast them. These are our talk objectives today. So before we delve more deeply into both of these infections, I think it's important to consider the taxonomy of gram-positive rods. You can divide gram-positive rods into whether they are branching or non-branching, and also whether they are aerobic or anaerobic or microaerophilic. So Nocardia and Actinomyces share the fact that they are both branching organisms. But a distinction is that whereas Nocardia is an aerobe, Actinomyces is an anaerobe. Nocardia also stains weakly acid-fast, whereas Actinomyces is acid-fast negative. Among the non-branching gram-positive rods, organisms like Cutibacterium and Clostridium are anaerobic or microaerophilic, whereas aerobic organisms that are gram-positive rods that are non-branching are the ones listed here at the bottom of the slide. They include organisms like Cyanobacteria, Listeria, and Rhodococcus. So as we said, Nocardia is an aerobic gram-positive bacillus. It's not a very common pathogen, although it's a pathogen that you don't want to miss. And it has the potential for local or systemic disease in humans and animals. It's typically associated with the immunocompromised in about 2/3 of cases, but approximately 1/3 of infected patients are in fact immunocompetent. Nocardia has a worldwide distribution, and although it favors temperate zones, it's present in all continents except perhaps Antarctica. Most cases occur in 3 specific zones: the Americas, Africa, and India. Now, distinct from Actinomyces, Nocardia is not a commensal, so the presence of any positive culture within a human being is considered abnormal. You can typically find Nocardia in the external environment. It can be found in decaying vegetable matter, in soil, in aquatic environments like what's shown here in the photo. It can become airborne on dust particles, which is a major way that it can be spread through an inhalation route. Inhalation most often results in lung disease, which can have several other complications. This is some microbiology of Nocardia. Similar to Actinomyces, it's in the order Actinomycetalis, along with Actino and these organisms. Early in its investigation, it was once considered a fungi because of its hyphae-like appearance, but upon further evaluation and examination of its cell wall structure, it was very consistent with a bacteria. A culture plate is shown on the upper left of the slide, and you can see the chalky white, waxy, or wrinkled colonies that require extended incubation. This is a gram stain of Nocardia, and you can see that it has kind of a beaded filamentous gram-positive appearance. And just to make a point, you cannot distinguish between Nocardia and Actinomyces on a gram stain. But you can distinguish between Nocardia and Actinomyces with an acid-fast stain or a modified acid-fast stain. Also, Actinomyces is an anaerobe, whereas Nocardia is an aerobe. This is a gram stain on the left of Nocardia, and you can see a modified acid-fast stain of Nocardia on the right side of the slide. Now, because Nocardia has extra long mycolic acids in their cell walls, they can retain carbylfusion stain during mild acid decolorization. Of more than 90 species of Nocardia, 54 can cause disease in humans. When I started in the practice of infectious disease, there were basically two strains of Nocardia, Nocardia asteroides and Nocardia brasiliensis. But through molecular methods, it was further determined that the organisms that were classified under Nocardia asteroides were really many different strains. So the current epidemiology of Nocardia, there are multiple different strains in the US, the most common of which is Nocardia nova complex, followed by Nocardia brasiliensis, and so forth. And this organism does have some geographic variability that can affect its prevalence by region. There are two major routes of transmission. Number one is through inoculation into skin, and number two is inhalation through the lungs. And inhalation through the lungs is the most common route of acquisition. Nocardia, I think, is notable in the fact that after you get the primary infection, it really can disseminate widely to almost any organ, particularly the CNS. And depending on your status of immunocompromise, it can relapse or progress even despite appropriate therapy. There are several specific modes of entry for Nocardia, but the most important is environmental. Again, people who are gardeners, who farm, basically you can get a percutaneous abrasion or puncture from outdoor sources like thorns or splinters, or abrasion with a moist outdoor surface. Under the right circumstances, you can become exposed. Healthcare associated sources are also significant. This is a organism that can be associated with surgical tourism, for example, or contaminated medical devices, surgical procedures where maybe contaminated implements can inoculate the patient with Nocardia. Animal scratches or bites also can spread Nocardia, although it's less common. And rarely, Nocardia can be transmitted in transplant tissue. As far as who is at increased risk, about 2/3 of cases occur in the immunocompromised. And these can be patients with solid organ malignancy, organ transplantation, either solid or hematopoietic stem cell patients, HIV infection, but an especially significant risk factor is glucocorticoid therapy. As far as malignancy, patients with solid tumors, hematopoietic tumors, and those on calcineurin inhibitors are at particular risk. Organ transplantation patients have a highest risk in the first year. It's really the association with steroid administration, which can increase that risk. With HIV, there are fewer overall cases of opportunistic infection because of the use of antiretroviral therapy. And let's not forget the primary immunodeficiencies. Now, in about 1/3 of cases, immunocompetent patients are involved. And so there may not be any recognizable immune deficiency in these patients. Among the immunocompetent patients, the following can increase risk: type 2 diabetes, TNF alpha blockers, chronic lung disease, and you can get Nocardia in the presence of concomitant mycobacterial disease. The onset of Nocardia can be insidious. The primary infection typically occurs at the portal of entry, let's say through some entry point in the skin, for example, for those who acquire soft tissue disease, and then also in the lung in those who may inhale Nocardia and develop a primary infection there. In about 20 to 50% of cases, the infection can disseminate. And the most commonest sites of involvement for dissemination are listed here. Pulmonary is number one, followed by cutaneous, multi-site, and CNS. And some miscellaneous other sites of involvement, such as ocular disease, visceral disease, bone or joint disease, and bacteremia can occur. Isolating nocardia within the pulmonary tissue, this is not normal. Any positive culture requires evaluation. Can we say that in every single case, a positive culture for nocardia from the respiratory tract of a patient is equivalent to active disease? No, but it should definitely be evaluated. An infection can present as acute, subacute, or chronic. You can have it as an exacerbation of an underlying chronic lung disease like COPD or sarcoid. And patients may develop chronic fever, night sweats, fatigue, cough, pleuritic chest pain, similar to what they may experience with non-tuberculous mycobacterial disease or TB for that matter. About 1 out of every 2 pulmonary cases do disseminate. So oftentimes you will want to do surveillance of the CNS with imaging in patients with pulmonary nocardia. And complications of pulmonary disease, again, are similar to other chronic lung infections and can include empyema, mediastinitis, SVC syndrome, and others. On lung imaging, there can be a variety of diverse findings. You can have unilateral or bilateral nodular disease. You can see the formation of cavities, consolidation, effusions. These are all different lung findings in a patient with pulmonary nocardiosis, as shown on the right side of the slide. Skin disease tends to be more common in immunocompetent patients. Primary cutaneous disease involves the direct inoculation of contaminated material or the organisms into the skin. I remember one of the first patients I saw with nocardia was somebody who was immunocompromised with acute leukemia, was neutropenic, and happened to be at home, was cleaning out the gutters at his home, and basically suffered an abrasion to his wrist when cleaning out a gutter against the sharp edge of the gutter, and developed cutaneous nocardiosis. The presenting symptoms of this can resemble an acute cellulitis. You can have an ulcer, pyoderma, or subcutaneous abscesses. These patients may stain culture negative for routine cultures and have a relatively poor response to short-term antibiotics. Lymphocutaneous disease can also occur in sort of a sporotrichoid form, similar to other causes of nodular lymphangitis. And you can have cutaneous lesions also due to disseminated disease. And what we see here on the bottom left of the slide is mycetoma foot, which is similar to that seen with actinomyces and can be refractory to treatment. Typically, this presents in patients with poor access to medical care. These are various manifestations of nocardia skin disease, including mycetoma foot, someone with skin and soft tissue disease on the lower left, a post-surgical wound infection at the top right, and a miscellaneous glabellar infection right in between the eyes on the lower right. This is a patient who did not readily seek medical attention initially, who is shown with extensive chronic nocardiosis. So as we've seen, CNS disease is the most common site of dissemination. Spread from a pulmonary site is common. CNS involvement, however, can be primary in about 20% of cases. About 44% of disseminated cases involve CNS disease. And you can have single lesions or you can have multiple lesions, reflecting the fact that this is a disseminated infection. It typically resembles a brain abscess with ring-enhancing features and a lot of surrounding inflammation. Symptoms of CNS involvement can include headache or meningismus, Patients can also present with seizures. These lesions can be difficult to differentiate with a CNS neoplasm. You can also have nocardia meningitis, and this can be mostly subacute or chronic, but when you do a CSF exam, it has morphology similar to bacterial meningitis. Miscellaneous infections involve dissemination from a pulmonary cutaneous site to really any organ. Bacteremia typically occurs mainly when the infection is associated with a foreign body. Bone disease has been described. Prosthetic valve involvement can occur. Joints or kidneys also, and these other miscellaneous sites, including ICD infections, mediastinitis, keratitis, pancreatitis, endophthalmitis, and so forth. The differential diagnosis of nocardiosis really depends upon where the disease is occurring. For pulmonary disease, it can present very similarly to other fungal infections. Actinomyces of the lung can also present similarly. You also want to think about Rhodococcus equi, non-tuberculous mycobacterial infections, and TB, and lung malignancy. For cutaneous disease, think about other syndromes that produce nodular lymphangitis, like Mycobacterium marinum infection, superficial cellulitis like strep and staph, erysipelathrix, francisella. Mycetoma, think about actinomyces and fungal infections. For CNS disease, primary CNS tumor, a bacterial abscess, vascular infarction, or a variety of other infectious syndromes like toxo or M. tuberculosis can present similarly. So in order to be able to diagnose nocardia, you need to, number one, have a clinical suspicion. And isolation of the organism is really imperative for definitive diagnosis. And also, even though we have more modern molecular methods of identification, you still need to get your susceptibilities. But nocardia doesn't really grow that well, and it can present in a very diverse manner. So as a result, it may be difficult to diagnose. But if you have a clinical specimen and a modified acid-fast stain is positive, you can perhaps make a presumptive diagnosis. Selective media like BCYE or a buffered charcoal yeast extract can aid in the isolation of nocardia, although most routine media can support it. Growth can be extended up to 3 weeks. An emerging useful diagnostic method is MALDI-TOF. Also, molecular next-generation sequencing can sometimes be helpful in these cases. And you always want to obtain speciation and susceptibility testing for all of these relevant isolates, as susceptibilities can vary by species. If you have somebody with extracranial nocardiosis and they develop CNS-related symptoms, you always want to neuroimage them. And really, all immunocompromised patients with cutaneous and/or pulmonary nocardiosis should be screened for CNS disease. If you have an immunocompetent patient with pulmonary disease, you should also screen them, but it's less important with isolated skin disease in the immunocompetent. And a brain biopsy is usually needed for diagnosis, as lumbar puncture doesn't often isolate the organism. What about the treatment of nocardiosis? Well, the important thing to remember is no prospective or randomized trials have ever been performed. So all treatment is really expert opinion. Susceptibilities, as I've said, are imperative because different species can manifest different susceptibility patterns. If you have somebody with mild skin disease, that's really the only clinical scenario where single agent monotherapy is acceptable. Typically, 2 or 3 agents with likely activity are recommended for empiric antimicrobial coverage. Nocardiosis follows an induction and consolidation strategy. Induction is usually for 3 to 6 weeks, followed by consolidation, which can continue for several more months. Severe disease should have at least 2 active agents, with coverage being subsequently weaned based upon susceptibility testing and clinical response. And there are oral treatment options after induction treatment, which can make the consolidation phase much easier for the patient to tolerate. What about specific agents? Well, Bactrim is a mainstay of therapy, but there is growing resistance, and not all strains are uniformly susceptible. Amikacin has the greatest susceptibility and durability, but other aminoglycosides are less reliable. Imipenem tends to be the most active carbapenem. Third-generation cephalosporins are less reliable, and the concern with using linezolid is extending therapy beyond 2 weeks with the possibility of side effects due to things like neuropathy and bone marrow effects with prolonged use. Some other oral antibiotics have potential activity, including minocycline, amoxiclav, fluoroquinolones, and dapsone. Tigecycline may also be an option, although that is parenteral. So here's a slide from up to date showing the treatment of nocardiosis, and you can see for isolated infection, generally speaking, 1 or 2 drugs are recommended. But for severe infection, your empiric therapy will usually be a combination of Bactrim plus an aminoglycoside plus a carbapenem, at least until susceptibilities are known and the patient is showing evidence of clinical response. What about prognosis and monitoring? Well, there isn't a lot of clinical data, and expert opinion really makes up the most of these treatment recommendations, but in general, skin disease can be treated with 3 to 6 months of therapy if uncomplicated, up to 6 to 12 months if complicated or immunocompromised. For lung disease, a minimum of 6 months, usually up to 12 months. If you have somebody that is severely immunocompromised, more than 12 months may be necessary, and CNS disease is usually treated for a prolonged period of time. Some severely immunocompromised patients may require secondary prophylaxis to prevent relapse. And if you have advanced AIDS, stem cell transplant, solid organ transplant, or are on glucocorticoids by necessity or chemotherapy, then treatment may need to be more prolonged. Patients who are on immunosuppression may be helped by reduction of the immunosuppression. These patients require close monitoring during treatment for clinical response and drug toxicity. And occasionally, surgical intervention may be necessary with soft tissue and chest complications and pericarditis. So we're going to go ahead and shift gears here and talk about actinomyces. So unlike Nocardia, actinomyces is an anaerobe. Like Nocardia, it is branching. Actinomyces was first described by James Israel. He was a German surgeon and pathologist in 1878. And this is the reason why the most common strain of actinomyces is called Actinomyces israelii. Now, unlike Nocardia, actinomyces is normal flora. It is a commensal. It prefers certain gingival spaces or tonsillar crypts, teeth with caries, periodontal pockets for which to thrive. It also inhabits the GI and urogenital tract, which is one reason why it can cause infections in these areas. The classification is very similar to Nocardia, as shown here. It's closely related to other organisms like Corynebacteria, Mycobacteria, Nocardia, and Cutibacterium. There are more than 30 species of actinomyces. Again, Actinomyces israelii is the most prevalent in human disease. But more recently, it seems like we've been seeing more cases of what was known as Actinomyces odontolyticus, but now is known as Shalia odontolyticus. And this organism has been associated with hematogenous dissemination. Now, unlike Nocardia, with actinomyces, humans are the only reservoir. And we don't tend to see a lot of these infections, but when they do occur, they are important not to miss. And unlike Nocardia, which is primarily an opportunistic pathogen. Actinomyces is mostly a disease of immunocompetent patients. Like Nocardia, actinomyces can be difficult to culture strictly because it is anaerobic or microaerophilic, and that requires strict requirements for transportation, processing, and growth. And growth may take up to more than 3 weeks. And if you want to recover this organism, you may require specialized media like anaerobic blood agar or Brucella blood agar with prolonged incubation. And again, actinomyces is indistinguishable from Nocardia on gram stain. Actinomyces israelii forms characteristic sulfur granules in tissue, but not in vitro. Shallia odontolyticus doesn't produce sulfur granules, however. Actinomyces can be isolated from mucosa because it is a commensal, so the presence of this organism in a culture from, let's say, the oral cavity does not necessarily mean it's a pathogen. MALDI-TOF identification, like with Nocardia, is emerging as an important diagnostic tool. So the 3 main areas of involvement for actinomyces are listed here. Cervical facial disease is most common, but you can also see thoracic disease and abdominal pelvic cavity disease. Remember, an important characteristic of actinomyces is it tends to ignore tissue planes. So if you see erosion of an infection or abscess across tissue planes in the appropriate location, whether it be the thoracic cavity, the cervical facial area, or the pelvic area, think about actinomyces. Oral cervical facial disease is the most common form. It tends to occur in patients with predisposing conditions like poor oral hygiene, smoking, poor dentition, diabetes, and patients who have head and neck cancer and develop osteonecrosis of the jaws. Some patients may develop a dental infection or have dental implants placed or mucosal trauma that may be an antecedent event to the formation of this syndrome. These infections progress very slowly in a matter of weeks to months. And so you may see a patient with a chronic wound of the mandible line or upper jaw line. The typical story will be that patient was given an antibiotic for 7 to 10 days and the infection got better, but it then worsened. And when patients usually present to you, this has been going on for several months. Chronic cases may progress to resemble malignancy. And so a lot of times these patients are frustrated when they present and they're looking for answers when they have not responded to any intervention. What about abdominal pelvic disease? Well, this typically occurs in association with abdominal infections or invasive procedures like, for example, lap chole, or they may have retention of a surgical sponge or the prolonged use of an IUD, hysterectomy or salpingectomy. Those have all been potential factors of abdominal pelvic actinomyces. The progression of the disease can resemble inflammatory bowel disease, abdominal pelvic tuberculosis, or malignancy. Most of these cases are diagnosed after a surgical procedure where tissue is examined, but a CT-guided percutaneous aspiration can also be helpful. Most thoracic disease occurs with aspiration of oropharyngeal secretions. Remember that this organism can cross tissue planes, so it can erode into the mediastinum or originate as an aspiration in the lungs and then erode into the pleural space, for example. It has a morphology that can be confused with regular bacterial pneumonia, TB, or lung malignancy. And in a case series, about a third were initially diagnosed as cancer. So this is a case study from my facility, and it involves a 76-year-old male with multiple comorbidities, including tobacco use, coronary artery disease, pulmonary hypertension, who came in with chronic cough and shortness of breath with foul sputum production. This CT thorax demonstrated some large right lower lobe consolidation with scattered micronodules. Patient had a bronchoscopy done 4 days later, and it grew 9 colonies Actinomyces Shallia odontolytica. So this was suspected of being a Shallia odontolyticus pulmonary infection, maybe with hematogenous spread. And the patient completed 3 weeks therapy with IV penicillin G, transitioned to oral penicillin VK for 3 months. Pre and post imaging revealed complete resolution of the infection. And you may ask yourself, was this a case of aspiration with Shallia odontolyticus also being found from cultures kind of incidentally, or was it a complete Shallia odontolyticus infection? Hard to say, but the important thing is the patient responded to treatment and improved. Other manifestations of actinomyces are shown here and can include cutaneous disease, musculoskeletal disease, CNS disease, either via hematogenous spread or extension locally. Disseminated disease can also occur, and some other infections like UTI, ophthalmic infections, infective endocarditis have also been reported. Diagnosis can be challenging because, remember, culture requirements are significant. But if you see actinomycotic sulfur granules within a pathologic specimen, that can be diagnostic. But remember, those are limited to Actinomyces israelii. They don't occur with Shallia. If you culture the actinomyces from pus or bone, this may require prolonged incubation, but it can be helpful. And remember that gram stain cannot distinguish between Nocardia and actinomyces, but only Nocardia are modified acid-fast positive. For treatment, penicillin therapy is considered the gold standard. If you have a serious infection, parenteral therapy is initially preferred. You can use penicillin G, ampicillin, or even ceftriaxone. And then you can step down to less aggressive oral therapy after a couple of weeks. The options there are oral penicillin VK or amoxicillin. But if you have a penicillin allergic patient, doxycycline, macrolides, or carbapenems also have activity. Induction treatment for actinomyces is usually 4 to 6 weeks, followed by consolidation therapy with step down to oral. Mild disease can be treated for anywhere from 2 to 6 months. Severe disease may require up to 12 months to respond, and treatment length should be individualized. Surgical intervention or debulking may play a role in complicated infections, and it's not always necessary to treat companion organisms in polymicrobial cultures unless they're felt to be true pathogens. So this is a comparison of the differences and similarities of actinomyces versus Nocardia. Now remember, actinomyces is a commensal, so it prefers certain body sites, whereas Nocardia's reservoir is the soil and it's a non-commensal. Actinomycosis typically occurs in an immunocompetent patient. Nocardia, in 2/3 of cases, is a disease of the immunocompromised, particularly those who have hematologic malignancy, are on steroids, are transplant patients, and so forth. The primary site of actinomycosis is the mouth, lung, appendix, uterus, and in those with an IUD, whereas the primary site for Nocardia is cutaneous or the lung. Actinomyces can primarily have contiguous spread versus Nocardia, which can disseminate more remotely, especially to the brain. And lastly, actinomyces has a very chronic course, whereas nocardiosis has more of a subacute course. And antimicrobial treatment strategies are shown here. and they are somewhat distinct. So to summarize, Nocardia and Actinomyces are related organisms within the Actinomycetia class. Nocardia infections more commonly affect the immunocompromised. Nocardia is primarily a pulmonary and skin soft tissue pathogen that can spread to the CNS, whereas Actinomyces primarily causes cervical, facial, and thoracic and abdominal infections. Both Nocardia and Actinomyces are diagnosed through clinical specimens and are difficult to culture. MALDI-TOF is an emerging methodology for identifying these organisms. It's more important to have susceptibilities with Nocardia species rather than Actinomyces, since Actinomyces seems to be universally susceptible to the antimicrobials we talked about. Both Nocardia and Actinomyces require prolonged treatment with distinct antimicrobial regimens. And really, making the diagnosis of both of these infections requires increased clinical suspicion. So be on the lookout for these organisms. They can certainly present in an insidious way, and they can also mimic other non-infectious and infectious diagnoses. These are my references, and thank you all for listening today, and have a great rest of your day.